So thanks everybody for joining us tonight. Looks like people are slowly trickling in. This is the trauma fireside. This is infected, now what? So tonight we're going to talk to you about all things fracture-related infection. I'm Jeff Marisek here in Los Angeles. And we have an incredible faculty for you tonight. We have Ashley Levack in Chicago at Loyola. And we have Willem Metzenmakers in Belgium, who is joining us in the middle of the night for him. So we definitely appreciate that. Just a few housekeeping things before we start. Here are the disclosures of financial relationships. These have undergone conflict of interest resolution prior to this, in coordination with the AO. The AO is a surgical specialty society. We are not here to promote specific products. Whenever possible, we'll avoid the use of brand names, but sometimes in a space like this where there are not many options, they'll sneak in. So we'll try to avoid that, but we're not here to promote anything. We're here to talk about the principles and how to manage things. This Trauma Firesides was developed through the AO North America and is designed to help cover important topics that we need to sort of discuss and go into in more detail. So we want you to be able to understand current journal articles, why a particular study was done, look at how things have changed orthopedic practice, and make decisions based on scientific evidence. Here's our plan for tonight. I'm concluding our welcome. Willem's going to give us a brief introduction to the diagnosis of FRI, because that's not something that, at least here in the US, a lot of our residents are covering yet. And then we've got a couple cases and one quick journal article to go over. So again, by the end of this, we hope we will be able to diagnose fracture-related infection, understand the use of antibiotic-coated implants, and then understand the indications for debridement and implant retention. So again, don't hesitate to use the question and answer box, and we're looking forward to chatting. So turn it over to Willem.
Thanks, Jeff. So indeed, before we go into the cases, a bit of some background on fracture-related infection and more specifically on the diagnosis and classification of fracture-related infection. So we all know that fracture-related infection, the term itself, is relatively young and was recently developed and focuses on a certain definition. And in the definition, we have confirmatory criteria, 5 of them, and a list of suggestive criteria. But when you have your confirmatory criteria, this means that your infection is definitively present. So one of those confirmatory criteria is a fistula or sinus or wound breakdown. In summary, this means just that you have contact between the outside world and your implant or the bone. And this is per definition a fracture-related infection. So in this case, it's a staph epidermidis infection on a clavicle plate. So the next confirmatory sign is purulent drainage from the wound or visual pus during surgery, relatively easy, of course. And the next confirmatory sign is 2 pathogens identified by culture from at least a single pathogen identified by 2 separate deep tissue or implant specimens. So this means also sonication fluid, and this accounts for 1 single specimen. This was also confirmed by a recent Oxford study published in the GBGS. But important here is that the author stated that you have to have at least you have to take at least 5 deep tissue samples with clean instruments to avoid contamination and make this sign really a confirmatory criteria for FRI. So important here is also that we focus on the fact that we want to prevent the use of antibiotics before we take cultures. So we try and avoid the use of antibiotics at least 2 weeks before surgery. Of course, this is not always possible. We want to minimize the manipulation of the target area. We call that a no-touch technique. This just means that you avoid, for example, giving the specimen to the nurse, and the nurse gives it to somebody else and then hand it over to the jar, for example. So, but we also need to avoid really the sinus tract samples and swabs. So swabs taken at the outpatient clinic or the ER are really no-go because they have a low yield compared to tissue cultures and a high rate of contamination. So this is, I think, a really important point that we have to acknowledge. Final confirmatory signs of histopathology, sometimes a little bit more difficult to understand. One of the first was the presence of microorganisms identified by specific staining techniques. We have to remember that FRI is not only a Western problem, or high-income country problem. When we look at the low and middle-income countries, for example, there is an endemic of TB and fungal infections, and here histopathology is really a key aspect. More recently, also the presence of more than 5 polymorphonucleus per high power field is confirmed specifically in the chronic late onset cases of infection as a confirmatory sign of infection. Here are still some controversies going on as other studies have not been able to confirm the results of this study. So this is really a summary of the confirmatory signs. When we look at the suggestive criteria, we have a list of clinical signs. We all know the local redness, swelling, but also fever. As a next step, we have also our radiological signs. The radiological signs, think about non-union, for example, on the next slide. But also the presence of periosteal bone formation. And of course, we all know the sequestration or bone lysis. Other suggestive criteria, which are less well known, is the pathogenic organism identified by culture from a single deep tissue implant. A recent validation study showed the importance of this for highly virulent organisms. Think about Staph aureus or Pseudomonas. But also the elevated serum inflammatory markers and the new onset wound drainage and periarticular fluid are can be very important and suggestive signs of infection. And this is something we all can find in these recent publications. The below one is the first consensus definition, and an update was published in GOT. I think here's mainly important to understand that we really try and follow a diagnostic algorithm, and we'll see that in the cases as well. A bit of a more difficult issue is, of course, the terminology and classification. Till now, we've seen that different terms have been used, and that's why we try and focus on a single term. It's fracture-related infection. Often still the term osteomyelitis is used in a worldwide setting. We have to remember this is a term that's been developed 100 years ago, but not specifically for fractures. It's for bone infections in general. And in many cases of FRI, the osteo is not really present. So it's a histopathological term, not really a clinical term. So when we look at the classification, which can really help us in guiding treatment, there is not a lot really available for fracture-related infection, and a lot of them are mainly focused on osteomyelitis. One of the most important ones we all know is the CNMARA classification published in 1984. What's the content of the CNMARA? I think we all know the anatomic type, medullary osteomyelitis, superficial and localized osteomyelitis. And the stage 4 is the diffuse osteomyelitis. Why is this all important? It really helps us to guide surgical treatment. So I think this is really important. And another aspect that is really good about the classification is the physiological classes. So you have your A host, normal host, your B host, which subdivides into systemic and local compromised hosts. And the C host is the fact where you have the treatment that is worse than the disease. The problem here is, of course, when we're looking at this classification, there are certain aspects that we miss. What about soft tissue coverage? What about the microbiology? Is it difficult to treat infection? What about the fracture itself and the construct stability? So today, still, there's no clear, robust evidence supporting any classification, and also not specifically a time-based classification or an anatomical-based classification. So I think this is important before we start the cases, and I want to hand over to Ashley to start with the first case.
Yeah. One quick question, Willem, while we're through the chat is, can you just quickly cover the questions? What's the strength of the evidence for 5 specimens? Is that opinion, or do we actually know that 4 or 3 is not enough?
That's a very good question. So no, I would say like the 2 weeks till 2020, that was more opinion based, but the Oxford group did a well-performed study published in the GBGS, the one that I showed, and really showed that the 5 cultures are very important. So I would say for now it's evidence-based. Yeah.
Yeah, I want to say it's been a while since I've read it, but if they'd only taken 3 cultures instead of 5, they would have missed like 10 or 15% of the organisms, something like that. So
yeah.
You definitely pick up more when you do that.
And also interpreting the results, of course, when you have a single culture with a staph epi, that's difficult. Is it contamination or not? So it's interpretation also. It's important to guide the treatment, to guide treatment at the end.
Excellent. All right, Ashley, take it away.
All right, I'll start off with our first case. So we'll go to the next slide. This is a 30-year-old male who actually presented to clinic. He initially went to an outside hospital after sustaining several gunshot wounds to the abdomen and lower extremity. And he underwent several procedures there, including an X-lap, colostomy, and an external fixator for the right lower extremity, which you can see here. At the time, they did sort of a limited debridement of the entry wound for his ballistic injury. And then he was planned to be transferred to our hospital from this other facility. However, the complicating factor was that he was discharged to jail. So he ultimately presented to clinic. And at that time, it was 2 weeks ago, 2 weeks out from the injury. His wounds were healing. He had minimal swelling and he was neurovascularly intact. So he was admitted and underwent further management with our team. He had his initial surgery performed where his external fixator was removed, his pin sites were debrided. He had another sort of limited debridement of his open ballistic wound, and then this intramedullary nail placed. He was discharged on post-op day 1 without complication, but returned on post-op day 12 with the images seen here, where he had draining wounds from both an anterior wound in the middle of the tibia, which was sort of distal to where his traumatic wounds were, and then also the proximal extent of his lateral ballistic entry wound. You can also see, if we go to the next slide, that his alignment has changed now on post-op day 12. So I wanted to kind of just shoot off some questions to the panelists about what you're thinking here and how you're going to manage the hardware in this setting when there's clearly a change of an alignment.
Willem?
My question actually was to start is, so the slide before, so you have the 2-week period in between the injury and the initial treatment. At that moment in time, were there any cultures taken, or was it just treated as an open fracture, fixed, and then the patient was sent home?
Yeah, so he was treated as a ballistic fracture. We can talk about whether or not you consider that open, sort of on the spectrum.
Different webinar.
Yeah, and then discharged to jail again, and this was the first time he returned.
Okay. So it seems to be a fistula, this wound drainage or an open wound, correct, Ashley? No? Yeah. Mm-hmm. So per definition, we think it's a fracture-related infection. And just to confirm, it's day 12 here, or yeah, so we are 2 weeks out at this moment in time. Yeah, I think at this moment in time, the main decision, Jeff, is are we going to keep the implant or not? In cases that early. For my feeling, also looking at the implant itself, I would personally probably go for a two-stage approach. I think already earlier on, there was suspicion of an FRI, so I would probably take out the implant, although it's very, very early. Yeah? So, I mean, this is typically ballistic. Yeah? We see that also with the Ukraine soldiers now. So although it's very early, I think we would consider here with this soft tissues to take out the implant and go for a two-stage. Aggressive debridement, take out the implant, and go at this moment already for an antibiotic nail, and then a second stage. And also see at the local status of the bone, of course, you could end up with a larger defect. So be aggressive at this moment in time.
Yeah, I think I would echo that. I mean, to me, once, the question is always, do you keep the implants or not? And once you've lost alignment, that you're this early on, it's a no-brainer to try to start over and fix the alignment. And I think that gives you a great opportunity to use a different implant to, provide local antibiotics, to do a better debridement. You may need to change your treatment tactic, et cetera. So for sure it's infected, right? It's already draining, and he's already lost alignment. So there's two things that we have to fix. And so this is coming out.
Yeah. How aggressive do you feel you need to be with these wounds that are draining, that are, limited soft tissue envelope in that area? So any debridement could risk the need for more advanced coverage.
Actually, for my feeling, first of all, I would be aggressive. So probably chances are high that you would end up with soft tissue coverage. The other thing is, maybe Jeff can comment. The problem is, of course, with these injuries, you can never get them totally cleaned. I mean, it's very difficult to get everything out. It's almost impossible. So it's a very arbitrary, term here to be very aggressive, because it's almost impossible to get all the shrapnel and all the iron out. I would be aggressive. We would probably end up with soft tissue coverage, but to say it's clean, it's almost never possible to say that you're able to get it totally cleaned up,
Yeah, especially for a guy like this, I'm not willing to skimp. This is in a location where it's very easy to rotate soft tissue if you have coverage issues. I think you really want to be very thorough with your debridement, right? Really make sure that you get everything. You're going to have to decide if that bone in the middle is viable or not, but I would not in any way limit the surgical exposure I need to do a thorough debridement.
Great. I agree completely. We can go to the next slide and we can see what was done. So in this case, I opted to remove the nail. Like you said, the alignment's already been lost. So trying to salvage that at this point, I felt was not a good idea. So I took the nail out. I did like we said, aggressive debridement of the sinus tract and of the proximal lateral wound. I used a medially based external fixator to maintain the alignment here, just as a temporary measure. And I irrigated the canal with the Reamer irrigator aspirator to try to, as best as I could, clean out any of the intramedullary infection present. And like Willem said, it's nearly impossible to get all of the infection out, but I did also opt to take out those retained foreign bodies, those retained bullets, as those could also be a nidus in this particular situation.
So a couple of things I wanted to ask here is one, I think here in the US, we all love using that device you mentioned for debridement of medullary infection, but is that something that you use, Willem? My understanding is it's not as popular elsewhere.
Yeah, good question, Jeff. I get the question often. For me personally, I use the RE on every case where I really suspect there's an infection. But you have to be honest. The main question is, does it improve the outcome of the patient? And for the moment, there's nothing to show that the RIA will improve the outcome of the patient. But where it helps from my side, we published the study a few years ago in JR, I think, is that you can take deep cultures in a very good way. So I use the filter of the system, and that material is cultured. And you see then in a lot of cases, you find different bacteria and pathogens than you find, which are, I would say, often superficial debridement. So yes, we use it. And yes, I like it to clean, you know, also because it's syringes. You don't always need to have an extra hole distally, for example, but also mainly to take cultures. Remember that sometimes you have to go into a curette when you don't have an open wound through, you know, the entry point of the nail. You get in touch with your skin, and then it's like, you know, is it really a good sample or not? And the RIA helps there. That's the reason I would use the RIA as well.
And actually, are you using this kind of antibiotic coated rod for all your cases, or only for sort of temporary use? And do either of you have any tips and tricks for how to fabricate these easily?
Yeah, so this is a 6mm Elizarov threaded rod with the end screw-on end piece there. This is what I use when I'm staging from an infection to the eventual definitive fixation. It's not very strong, obviously, so I left the external fixator in place, but I find that with this construct, I can easily create an antibiotic-coated nail and not worry about debonding of the cement, which I worry a little bit more about when I use just a ball tip guide wire. In this case, I actually did the antibiotic coated rod twice as both a temporizing measure to clean outs before moving on to definitive management. But this is sort of my standard.
Same here, Jeff. So for me also, I would go for an intramedullary PMMA implant, temporary implant. The question you always get, you know, from the residents is, what do you use? How many antibiotic can you put in? Which type of rod? So for me personally, I tried a lot of things, including also the Elizarov rods, and I think everything works. You can use the chest tubes, and it's all fine. You have to remember just that, you know, you have a lot of different types of cement in the US, in Europe, and you really need to practice a little bit what works for you. I think that's very important. What I do now is I hand roll them, meaning, I mean, you can see that maybe in some of the articles that we published. We use just the entry pin of, for example, the TFNA or the ETN set, just a standard entry pin, which is very stiff, and we roll the medium viscosity cement over it. So whatever you like to use and what your experience, you can use, and Elizarov is perfect. It would just be nice in the future to have something readily available instead of, you know, taking 30 minutes of our time in the OR. But that's maybe something for the future.
I do have a slide in a little bit later on about how to create this type of antibiotic coated rod. But I just wanted to make one more comment. The other indication where I might use something like this with the Elizarov antibiotic coated rod is if the fracture is healed or more stable, but I still want to provide local antibiotics, and I don't think it necessarily requires a statically locked nail. Sometimes this is an alternative in those situations. But we can go to the next slide. So this patient ultimately got 2 debridements with 2 antibiotic-coated rods that were exchanged. He was growing MSSA from his initial debridement, and so I switched up the antibiotics ever so slightly for the second antibiotic rod. And I think on the next slide, we'll have some sort of pictures of that. So my standard mixture to deliver a high dose of antibiotics through the PMMA is essentially 10% of antibiotic by dry weight, and each bag of The typical PMMA that we have here in the US at least is 40 grams. And so to get 10% of the antibiotic, you have to have about 4 grams of antibiotic per bag. So you end up having a lot of antibiotic on the field. Usually I try to do about 2 grams of vancomycin and 2.4 of tobramycin per bag of cement before I have culture results. And then you can tailor different mixtures depending on your culture results going forward. So for the second debridement, I actually used vancomycin and cefazolin, given that we knew what his culture results were. On the left, you can see that that's a chest tube. That's a 36 French chest tube, which will accommodate about an 8 to 10 millimeter nail if you're trying to coat something larger than the Alizarov. If you're trying to do coated nails for the femur, you'll have to go up in size to a 40 French, or even they have cardiovascular tubing, which is about 12 to 13 millimeters in diameter. But for this purpose, this was just a 36 French chest tube. You can see there that you have to make a slit along the edge to kind of open up the chest tube as to extract the nail. And the one key tip here that is critical is don't let the cement harden entirely before you go to cut off that chest tube, because the cement will bond to the chest tube and it'll be very sticky and difficult. So you want the cement to be firm, but not so hard that it bonds to the plastic.
Ashley, we have a question. Where did you get that 10% antibiotic by dry weight?
That's just the standard in the literature for what's considered a high dose antibiotic loaded cement. So when you have some of the cement companies have sort of preloaded cement mixed within the PMMA, and that's only about 2.5% by dry weight. And that's a low dose that retains the mechanical structure of the cement. But in situations like this, where we're not going for mechanical, structure, we're not putting in a knee replacement, we go up to higher doses to achieve higher elution properties. So 10% is just the general number in the literature of a high dose delivery.
And that's what you guys used in your elution studies?
Mm-hmm.
Okay.
Perfect. So this is a picture of his anterior tibial wound after debridement. Again, it was fairly quote unquote aggressive to excise any of the tissue. There was some bone excised through his other incision as well. But clearly this is a defect where he will require soft tissue coverage. So 8 days after his initial debridement, he ultimately went for definitive fixation. And in this case, repeat cultures were taken from the canal, which were negative. I wanted to ask both of you, do you wait for negative cultures before definitive fixation, or do you take cultures at the time of definitive fixation, and what do you do with that information?
It's a very good point, Ashley. So in the old days, historically, also the plastic surgeons, they didn't want to come or touch the patient the moment that you still had positive cultures. I think we have now data enough that you don't need to wait for negative cultures. And it sometimes means that you have to wait weeks. So we would take cultures, but we will not wait till the cultures are negative. We would really try and cover as soon as possible.
Yeah, I do not resample unless I feel like I didn't get an accurate diagnosis the first time. One question I had about this. So first off, on the antibiotic rod note, Dr. Sirkin says if you keep the rod cool with a towel, you can let it fully harden and it may not bond. I know some people have used mineral oil. I personally use a silicone tube so that I can let it dry and I don't have to worry about that. Because I get distracted by going back and doing more debridement. So I don't like to have to watch that. So there's lots of little ways to get around that. But cool towel, mineral oil, don't let it harden, or silicone tube. Any other, or hand roll it.
All good techniques.
Yeah.
For this nail, actually, On here, I do not see any sort of local antibiotic deposition. Did you use any for this? If so, what kind? If not, why not?
This is a patient that my partner and I kind of shared over time, as one of the other of us was available to, on that given day. And so this particular definitive fixation I did not perform. There were no antibiotics used during the definitive fixation. I think options, though, for the definitive fixation include coating the static nail with PMMA. Some people have also started using calcium sulfate in the intermedullary canal and then inserting a nail, which is also an option here, or calcium sulfate beads, resorbable beads at the site of the bone defect. It could also deliver additional antibiotics. I think all of those are very reasonable choices. And if I were doing this today, I probably would use a statically locked PMMA coated nail and some resorbable calcium sulfate beads at the site of the defect.
Willem, would you do anything differently, or what's your take on local antibiotic deposition versus systemic?
So I think the local treatment is very important. So I would indeed try to use it for sure. Again, this is a difficult case. What we shifted over the last 5 years a little bit from the calcium sulfates, not only because they're expensive, but because we see a lot of wound leakage. So when you have very good soft tissue coverage, it's fine, like a flap or anything else. The studies show that. But if you don't, then I'm really hesitant to use the calcium sulfates. You could go for bioglass, or just the PMMA, for example, would also be an option. The coating of the nail, yes. The issue is a little bit that also there historically in Europe it has been done. The issue is sometimes for me, if you don't remove the nail and it stays in, and the patient comes back, let's say 10 years later, with a small fistula and a low-grade infection, it's very difficult to get that cement out. And that's something that there are not a lot of studies on. So I see a lot of use of them, but I would be a little bit careful in leaving them in for a lifetime. That's the only thing that I'm a little bit careful with. I think it works very well, but I would often in my own practice try to keep it temporary and not definitively. Also just coating the implant, I mean.
And do you have access to some of the various proprietary coated implants, and do you think that's sufficient for this, or do you still make your own?
No, we have access, but I mean, I think they're not a lot. You have two. I mean, it's the Bactiguard coating and from Zimmer Biomet, and you have the Protect coating from Synthes. But to be honest, both are really prevention measures, not treatment measures. So I would not go there. They will not treat the infection. That's sometimes maybe stated in a wrong way, and I would really be careful to state that they will treat your, let's say, osteomyelitis or fracture-related infection here. I would not go there. I would maybe use them. That's something else, but I wouldn't say that this really would clean out the infection. I would always combine them with something else locally here.
And how are you guys handling IV antibiotics or systemic antibiotics? Are there any situations in which you'll forego them? And how are you making those decisions, and for how long are you typically doing it?
For us, Jeff, that means that we have a multidisciplinary team meeting every other week. We'll discuss the culture results and then decide. We come from times where the antibiotics are given 6 to 12 weeks. It's done now. The Oviva trial in New England showed that it's not necessary anymore. So when the culture results are available and the wound is dry, I would really go for a quick shift to oral antibiotics. When the implant is in place, for us, it would mean 12 weeks, sometimes even longer, depending on the union time. When there's no implant in place, it's a maximum of 4 to 6 weeks. Oral, not IV, when possible.
And similarly, ours is a multidisciplinary approach involving our infectious disease team. And they have not yet made the switch based on the Aviva trial about the IV versus PO, but typically 6 weeks duration. And then if a fracture is not healed and there's an implant in place, the switch to PO, suppressive antibiotics until union is sort of what I've seen. But I agree that IV antibiotics, given the data out there, maybe not necessary for that duration. This patient actually refused IV antibiotics, so he went straight to oral from the hospital.
All right. Any other, one thing you mentioned earlier, Willem, was, doing a 2-stage or a multi-stage approach as opposed to a single stage when you're doing an implant exchange. So how do you make that decision, Ashley or Willem? And do you find that one approach is better than the other?
The problem is, compared to the periprosthetic joint infection data, is that we in trauma have no data. Is it better single stage, 2-stage, whatever, so that's a really difficult discussion. The only thing is I would be relatively aggressive relatively early on. So this means in this case, when you would suspect after 2 weeks of maybe this is already a fracture-related infection, then we would go for a 2-stage. For us, a 2-stage means in the early days, it was, we would wait 6 weeks, and we had 2 weeks of a holiday interval, and then we go back. But that's, we wouldn't go there anymore. It means now 2-3 weeks, a short interval, like in the PGI literature, and then the definitive implant is placed and the soft tissue is closed. Whatever means possible. That's way, if you need plastics, it's plastic. But the interval is becoming very short. Yeah.
Ashley?
Yeah, I agree with that. I think the interval is getting shorter and shorter. And in this case, it was only just over a week. But I think what matters for me is how the wound is looking, and if there's any further necrotic bone or necrotic tissue on the subsequent debridements. I feel more comfortable putting in a definitive implant when the wound bed is clean and everything, all of the tissue looks healthy. If there's any question about further demarcation, then I continue to stage. So that was the reason for the second debridement and then the definitive in this situation.
Awesome. Any comments, anything we missed, anything you guys want to discuss further?
Is anybody using bioglass? That's something in Europe that's becoming very, a lot of surgeons use bioglass now instead of the calcium sulfates, but I'm not sure in the US, is it available? Do people use it or not?
I personally have no experience with it. I don't know that it's available to us quite yet.
Yeah, I've not seen it. I'll have to investigate. Maybe we have some illustrious people on the chat. Maybe they can tell us if they've had it, but I've not seen it here. Mostly here, it's either calcium sulfate or the biphasic calcium sulfate hydroxyapatite.
Okay. Yeah, so the bioglass is more like a ceramic glass type, but it has no antibiotics. But due to ionic differences and pH differences, it realizes the cell wall. So the good thing is that it's a little bit cheaper. Well, it's much cheaper, and it has no antibiotics, so you wouldn't get any resistance. And it also it's more osteoinductive, so it would improve your bone healing. But still, again, trauma, not a lot of data. So I mean, probably we have a different discussion in a few years when there are more studies out. But I think for this case, I think it's really important to have local treatment here. So I think that's really important.
We have one surgeon saying they do have access to bioglass. So
okay,
I have to make some phone calls. Anything else on your case here, Ashley?
Nope, we have about 8 months of follow-up if you click through, and he remains incarcerated.
All right. Very nice. So just in summary, implant exchange, local antibiotic deposition, ensuring everything is clean, good diagnostic approach, so on. So we'll move on to the second case here. This is a patient of mine who sustained a bicondylar tibial plateau fracture while skiing, and had a knee spanning external fixator placed and had a single incision fasciotomy for compartment syndrome. And for whatever reason, his original x-rays got deleted from our system, but here's some representative CT scan slices. So kind of a split on the medial side and a pretty impacted lateral articular surface. And he had his wounds closed prior to any surgery, and then went on and had this this repair. And unfortunately, about a month later, he had some drainage from both the medial and lateral wounds. So, Ashley, what are you going to do when you see that?
Duration out from surgery, if you're having surgical wound drainage, that's a concerning thing that warrants an operative debridement, unless it's a very superficial and benign appearing type of thing. So any drainage that I feel is deep, they get an intervention in the operating room. But of course, at 1 month out, nothing's going to be healed, and this is a complex articular injury. So I would strive to keep the implants in place, unless something is grossly loose or not functioning.
Willem?
Yeah, I fully agree with Ashley. I think we showed in a validation study the importance of wound drainage, and also the new onset wound drainage, for example. I think those should be addressed as alarming symptoms. Sorry. And so for me personally, indeed, if again, like Ashley said, I think if you have something like that in this case specifically, I would go in and clean out, take cultures, and treat it like it could be infected.
Yeah, I think this is, as someone who receives referrals for infection, this is a pretty common story where, maybe someone starts to get some drainage, they get put on some antibiotics, the drainage dries up, and they get told, oh, it was, no infection. And then later they have a much bigger infection. So it anecdotally, to me, once you see drainage, that's a confirmatory criteria. You got to get in there and go after it. I don't know if you guys have had the same experience.
Absolutely.
Agree. Yeah, fully agree.
And so once you're in the operating room with this case, how are you going to approach your management? Obviously, you said take cultures, and Willem gave us a nice talk on 5 cultures, no touch technique, etc. Are you doing anything else in the operating room to do this, and how are you deciding on, Ashley, you mentioned retaining implants, but how are you officially making that decision?
So the initial debridement for me involves debriding the hardware and the bone with curettes, scalpels, etc. I use a pulse lavage, as I think there's some basic science literature showing it can better disrupt biofilm. And then I will sometimes use some of the additional irrigation solutions that are on the market. Some have chlorhexidine, others have sort of more of an acetic acid base, but also just trying to disrupt any biofilm that may be present on the implants. And then I test the hardware to make sure that the screws are not completely loose, and that they're functional.
And Willem, anything?
Sorry, Jeff, I'm a little bit old-fashioned. This means that I tell the residents that as well. So I think the surgical part is the most important, meaning to be aggressive where necessary, indeed, correct scalpels. But then I only use low pressure. We use only saline, and so no additives. I think that's and coming a little bit from the literature, I think if you look at the last 5 decades to 6 decades, there's been shifts to iodine and chlorhexidine, and then now you see different commercial products also coming on the market, but none of them have really proven value. And we did a lot of research in the lab on all the different additives, and all of them are toxic to human cells. So it's a bit of a balance. We don't really know, the evidence is not really strong. So I stay old-fashioned until we really know what we need to use. For me, it's saline, and it's low pressure.
And is your attempt to control biofilm just prompt action, or is there anything else that we can do?
It's prompt action and aggressive surgery. But it's of course it's a little bit interesting, because if you really think at that moment in time, it's going to be difficult to remove the biofilm. The biofilm will be also on all the screws. And just getting the betadine or the chlorhexidine or any other product inside, it's not going to reach every aspect of the plate and screws. So for me, it's surgical and see that the implant is stable. I think that's really important in this case. But I mean, the evidence is almost non-existing. So it's experience. I think for everybody, it will be a little bit of experience. There's not really a good or right or wrong answer here.
And then, are you guys doing any sort of local antibiotic deposition in the wound after you close or in between debridements, or do you just try to get it back closed again?
It's a good question and a very difficult one. Why? Because yes, I think in these cases it's very important to use local antibiotics, but the question is what will you use? What's on the market? There is almost no good carrier. So we have some collagen fleeces, but also there, at the end, when the antibiotic is gone, it's more like a remnant or a foreign body, which is not really perfectly ideal. You can use them, You have the Vanco powder, just alone Vanco or Gent or Tobra locally. The problem, I think, currently is that we know we have to use something locally, but in every case, it's looking what's the most optimal local antimicrobial that we can use. I'm not really a fan of using the calcium sulfate subcutaneously. It's for me, it's in the bone. When you use it subcutaneously, your wound will open, So you see that sometimes pass by on cases and referral cases. I'm not really a fan of that, to be honest.
I agree at least here, the options are really antibiotic powder or calcium sulfate beads. And in this situation, especially along that medial plate, I think it'd be hard to get good fascial closure over top of beads. And so I would opt for probably local antibiotic powder. Again, there's no evidence in treating infection with local antibiotic powder. That's all with preventative type of studies looking at prevention of FRI. But I think that that's the option that sort of is available at the moment.
So we have one question too. Is the hope that early debridement as opposed to suppressive antibiotics to increase the longevity of the implants before you have to remove them, to make them last, to avoid the need for removal at all, to place local antibiotics, to get cultures? So I would say obviously yes. Number one, we want to get cultures. Number two, I think you want to remove non-viable tissue and things that can be removed. And then at that point, you have to decide if you're going to keep the implants or not. But I don't think just suppressing them with antibiotics, you won't know what bacteria you're treating or attempting to eradicate or suppress, and won't necessarily get as good a control as you could.
Yeah, fully agree here. I think that's really an important one. I think at this moment in time, you really have one shot and you want to know what your enemy is. So I think a key aspect will be to take cultures and which antibiotic you have to give at that moment in time. So indeed, and then the question is, whatever pathogen you find? Is it a difficult to treat one? Meaning, is there, do you have something available against the biofilm like rifampin? Because you have to decide, is it a curative approach or a suppressive approach? And going in early, you always hope it's a curative approach and you can keep the implants. And so that's the main reason here.
All right. And then last, or I guess the one other thing I would say is that, right, obviously Willem, you have some evidence that the shorter time interval or however fast you can get to it improves the chances of success for when you're doing a debridement and implant retention, correct?
Yeah, so we did. There's a systematic review that we done on the topic. The literature again is not great, but it shows compared to PGI, and it's really important that there is no single cutoff in time that will decide if their approach, keeping the implant, will fail or not. So even at 10 weeks, there are studies with 60-70% success rate. So it's important to discuss with the patient why you do their approach. In this case, if you remove everything, you will lose the joint, and it's going to be a big issue. And even after a period of 4 to 6 weeks, you can still have a high percentage of success, with these cases. Although, for example, in PGI, we think 4 weeks you have a mature biofilm, everything needs to go. It's different. It's different in trauma, but again, the data is not great.
Yeah, I mean, one of the things that I tell my residents that a mentor had said to me is the only thing worse than an infection is an infected non-union, and so we want to keep these in here to keep all the work we did whenever possible. Yeah,
and you're right. I mean, by the end of the day, of course, over time, your success rate will drop the longer you wait. That's clear. I mean, that's the conclusion, of course. So you don't want to wait too long. So going in as early as possible to have a high success rate is important.
And Ashley, any other comments? Anything we missed?
One other question for you on the management. If, let's say, only the lateral wound is draining, how aggressive are you being about opening the medial side and or opening the joint for your debridement?
I'm pretty aggressive about opening things back up. The caveat would be, if you had an extraordinarily tight closure or a very difficult closure on the medial side, and it really looked pristine, and my surgical exploration did not leave me there. But in a normal host with normal soft tissues, I would open both and open the joint. I've definitely from experience learned that things like saying, "Oh, the fascia is intact, it can't be deep," or don't work, right? So I've made that mistake. You don't need to make it for yourself also. Willem?
Fully agree. Yeah. And it's often with your own patients that you think, so that's something where you learn you should just open and clean. And I fully agree. Yeah.
Well, so these were his x-rays still after the initial debridement, and we opted for implant retention. He had staph epidermidis in all the cultures, so it was definitely not just a contaminant, it was an infecting organism. And I forget what he got put on originally, but he developed ITP and then had to get changed to some different antibiotics. And so this was him, down the road at the point where we felt like he was healed. So how do you have the conversation with these patients about the need for potential future implant removal? Are you going to leave it in place and wait until something starts draining? Are you prophylactically removing them while you're still on suppressive antibiotics? How do you have that conversation and make that decision?
I think if the fracture has healed and there's no signs of infection clinically, I think it's reasonable to wait and see and stop the suppressive antibiotics once the fracture is healed and let it declare itself. Once you have union, the management is a lot easier. But I don't know that a surgery is mandated if he's having no symptoms and has healed the fracture.
I think important here is to take a few things into account. Not specifically for this case, but it also depends, for example, on the time. When it's a simple S. aureus infection, 3 weeks out, it's a curative approach, then you can leave the implant in. You have a 99 or 98% success rate. Of course, it's different when you have a difficult to treat infection with a quinolone or rifa-resistant strain. It's 10 weeks out, and it's more suppressive approach. Then it's something you need to discuss with the patient. Like, yeah, I mean, chances are high it will come back, you know. So following them closely, and then I would have a lower threshold or maybe discuss with the patient to remove the implant. So it depends a little bit the time, the type of pathogen, and of course the patient, you know.
All right. Yeah, I find that, you know, a lot of the infectious disease doctors that we work with are, you know, just want everything out immediately. You know, they would like us to take it out at the first debridement, but, you know, the idea of leaving things in there permanently is anathema to them. So a lot of times it gets put in the patient's head, you know, even before we've gotten to this part of the treatment protocol to even talk about it. This particular patient was extraordinarily nervous, was very concerned about, you know, recurrence, had been on suppressive antibiotics, and, you know, was concerned that, you know, he may need a knee replacement in the future anyways, and these implants would just be in the way. So he asked to have them removed, which we ultimately did, and he's been doing all right. No evidence of recurrence, etc.
At what time point are you comfortable taking out those implants for him?
I try to wait for a full year. For him, I want to say this was at about 9 months, and we had a CT scan that really showed, you know, solid union, or at least as solid as you could get, you know, with a metal artifact on the CT scan. But we were convinced that it was well healed on imaging and based on his symptoms and time. One other question I had is, you know, we use various adjuncts in the periarticular region. Here you can see there's some fibular allograft, calcium phosphate, putty, you know, etc. How aggressive are you guys about removing that if you're doing an implant removal? Is it different in the acute infected setting versus in the late setting of, you know, we're just taking out the implants after a hopefully curative approach?
I think in this case, I wouldn't take them out. You would probably destroy more than you want to, so it's integrated, and I would really leave it in. Of course, in earlier settings where you have a severe infection, maybe uncontrollable, and you see real loosening during the debridement, then I would take as much of the material back out. So that's a little bit of the differences, of course, in the patients and the timeline there.
Yeah, I agree completely. If you feel that you've achieved a curative solution, then removal of those types of things can leave a void that can then set you backwards. But if you do not have control of the infection, then those types of things can be a nidus. And so taking out calcium phosphate and putting in a cement spacer is an option if you feel that the infection still needs treatment.
All right, so looks like you think you can do your other case in like 5 to 10 minutes, Ashley?
Yeah, sure.
All right, so
All right, so this is a 76-year-old male who presented to the emergency room with left knee pain, which had been going on for about 3 or 4 months, unrelieved by some medications such as gabapentin provided by his primary doctor. This is what his initial x-ray looked like in the ER. And he did also have elevated white blood cell count and elevated inflammatory markers to go along with this. But he had no draining sinus, he had no wounds, a little bit of swelling, but no erythema. So I wanted to kind of pose to you guys what you think about his imaging and what further imaging you would go to next.
Jeff?
Yeah, I mean, it's sort of a vague story, and for a lot of, these, I always try to probe about, what happened when they were kids, or did they have any history of trauma, all these kinds of things. I think particularly on the lateral view, there's some concerning signs in the distal femur there with, what may be a sequestrum or something, but sort of this elliptical ring of cortical bone that would make me concerned or want to dig a little further with advanced imaging. And just depending on his insurance and things like that, meaning how long it takes for those things to be approved, may get a CT or preferably an MRI.
Yeah, same here. So we would probably in this case also prefer an MRI. Although with new imaging and the FDG PETs, and I like that for surgical planning reasons, but in this case, we probably prefer the MRI. Again, it's also indeed a bit of a vague story, so give us a little bit more info.
Yeah, he's a pretty reasonable host. Very few systemic diseases, no history of trauma to the limb, no wounds in the area, no recent infections in other locations. There was really nothing that would kind of point to the etiology of this. We did get an MRI for him, and as you can see here, there's involvement of the intramedullary space as well as a breach of the cortex posteriorly and abscess formation posteromedially. And just a couple other views to see the extent as it goes proximally and distally within the metadiaphyseal region. So he did have a biopsy first, which did confirm infection, and then went ultimately for a debridement. I just wanted to ask both of you what your strategy would be here, given that it's in the intramedullary space, but there's also an abscess that's exiting in a region that's difficult to open up further and debride.
I would try and open it distally as much as possible and clean out the canal. When there are signs on the MRI that it would creep up and even higher, then you could even suggest reaming the canal. But in this case, I think you can really clearly see the distal part and try and open it in sleeve way and clean it out and fill it in afterwards.
Yeah, I think that my primary approach would be to, just go straight in, direct lateral and window things. Yeah. I would not be hesitant to make a counter incision on the medial side and go after the soft tissue abscess and look at that. But try to limit the cortical window to one location if possible.
Yeah, that's exactly what we did. So we can go to the next slide. So this is the lateral aspect of the knee. And essentially what I first did was an osteoperiosteal elevation along the cortex just to bring blood supply to the area, but then created this sort of lateral bony channel or window with a burr and constant irrigation so that I could have access to the intramedullary canal from that lateral side. And using the preoperative MRI, kind of knowing the dimensions of where I need to access, making that channel long enough to ensure that I got debridement of the entire affected area. but not making it so wide so as to destabilize the bone, since it is a fairly long channel there. And so the idea is just resecting any non-viable bone and infection that's living in the intramedullary space. And then I also, as you mentioned, made a counter incision medially to access the abscess directly and debride and evacuate the abscess from the other side. In this case, I did use local antibiotics, and we can go to the next slide. And you can sort of see on the x-ray there that there are very small beads in the intramedullary space, and those are calcium sulfate beads, the smallest ones I could make to fit them in that space and fit as many of them as possible to increase the surface area for elution. And I did place a drain posteromedially to evacuate any further fluid collections from that area.
You have any comments on this, Willem? Are you using similar local antibiotic control? Are you doing multiple stages?
No. I would really indeed try and go for single stage, getting it cleaned. Even when you have soft tissue problems, here again, the Oxford group showed that single stage works fine. It's just logistically not always possible. And I mean, we also used the calcium sulfate beads and I think in the femur it's fine. It's perfect that you place a drain again also for fluid production from the beads. For the tibia, again, we had a lot of problems. So for the tibia, when you don't have a lot of soft tissue coverage, really we stopped using it. And then it's more something like bioglass, something that really doesn't give that much of a fluid production and brings the soft tissue status, or that really compromises the soft tissue status. But for the femur, no, it's perfectly fine. Yeah. And indeed, very good. Plays a drain for the extra fluid that will pop up in the upcoming days. So similar approach.
And is there anything different about how the two of you approach a case like this, which is not necessarily a fracture-related infection case, but is nonetheless an infection or osteomyelitis case?
No, I think the general aspects are the same. And for me, in my narrow thinking field, it's all fracture related, at least a lot of them. Some of them are pure osteo, when you think about the children, for example. And again, be aggressive and have a low threshold also to clean out the canal when necessary on any doubt on MRI. So I think that's a bit of a similar approach, like in this case. I'm not sure if Ashley is something else.
I agree. I think having an implant in place or a fracture that's not healed brings different considerations, but in a stable bone, I think the one-stage approach is very reasonable.
Maybe one interesting aspect is that we see over the years that we have a lot of chronic infections like these that are fracture related from the 70s, from the 80s. I'm not sure if it's in the States is the same. Those were initially treated suppressively, and then like a small fistula that was present and they just left it, But then the patients become a little bit older and they come back with larger fistula. Some of them became septic, and then it's a problem because they're like, the infection has been present for 30 years. And it's difficult to get rid of it in a single stage, to be honest. And we're looking even further than just standard antibiotic treatment to get those infections, cleared.
Yeah. Excellent. No questions in the chat on this. Ashley, you showed here making some of the calcium sulfate beads.
So a few notes on that. If you add tobramycin powder to the calcium sulfate, the setting time increases dramatically. So one trick there is to use tobramycin liquid and replace the 6 milliliters of liquid that come with the package with the tobramycin liquid, and it decreases your setting time dramatically so that you're not waiting for too long for the beads to set. And I think the only other point on using these calcium sulfate beads is that elution corresponds to surface area. So I try to use the smallest beads possible, which would be the 3 millimeter ones on the right-hand side there, whenever possible, whenever it's feasible or reasonable.
Yeah. All right. And so here's follow-up for your case. You can see that the beads eventually dissolved and things look pretty good. All right. So the last part of this, start sending in questions now, because we'll take those and answer those as a group. But one of the things we want to do is just cover some interesting literature for you guys as well. So this was a paper that I found, or when I read it at the time, I thought was very interesting, just because of, I think the practice patterns here in the United States, at least, are very heavy on negative pressure, and particularly if you're working with plastic surgeons, are very heavy on negative pressure wound therapy. And so actually, Willem was one of the authors of this paper, but they did a review of patients from 3 level 1 trauma centers in Belgium and the Netherlands, and excluded those patients who were using negative pressure prior to the diagnosis of FRI. So only seeing how it affected them when it was delivered after the initial debridement. And then they looked at the risk of recurrence with and without negative pressure wound therapy. And so this was the enrollment, protocol, or how things went. Basically, you can see there were 400 total patients over this 3-year period at 3 centers, and they ended up with decent sized groups on both sides here. And these are kind of the main points of emphasis, which is, when you compare patients between the negative pressure group and the no negative pressure group, they were similar in terms of polymicrobial infection or culture negative infection. But they differed in how closure was achieved. In the negative pressure group, almost 45% were closed by secondary intention. And you can see that there's a massive difference in the amount of FRI recurrence. So 28% compared to 11.5 or 12%. And then there was a univariate regression, which didn't really show anything, but on multivariable regression, you can see that the duration of negative pressure wound therapy was the only thing that was predictive of recurrence. And so the longer that you're using it, the more likely it is to come back. And so some of the things that I thought about this when I read it, and I'd be curious to hear both of your thoughts, and especially yours, Willems, is this something inherent to negative pressure wound therapy? Is it how we do the dressing changes? Is it, a specific sponge? There's sponges with silvers. There's sponges where you can inject antibiotics. Do you think some of this is just improved local biology from having flaps and not doing secondary intention? What pouches or what dressings are you using in between debridements? Are you using, moist gauze? Are you making a local antibiotic depot? And is this more about, time to coverage? Is shorter duration just shorter time to coverage, or is it something else?
Yeah, Jeff, I think it's not only I would say problem in the United States. I think it's worldwide, specifically also in Europe, in the Netherlands. If you see the duration of negative pressure wound therapy that is used, it's extreme. Sometimes it's really months, and that's not only a logistical problem, but sometimes the plastic surgeon just says, "Listen, it's just secondary attention, secondary healing, and we just wait." And also for the study, of course, it's a very heterogeneous group often of patients in trauma. That's a problem inherent. You have a group with more soft tissue problems than another group. It's inherent is also a larger risk of recurrence. So that's why it was a very difficult study to perform. But by the end of the day, it shows a little bit what we all feel and see. is that the longer you wait for the definitive soft tissue coverage, the higher risk of infection. So does it mean that we don't use negative pressure therapy anymore? No, the issue is just we would really try and shorten the period to 7 to 10 days and then stop, and not longer than that. But this is not totally new. We see similar results from severe open fractures, for example. The long-term negative pressure wound therapy use is not ideal. The Wolf trial showed that as well. So I think by the end of the day, it's important that we look for a short time till soft tissue coverage, definitive soft tissue coverage, and keep the period of negative pressure wound therapy, which is not a therapy, it's a wound dressing, as short as possible. Do the wound dressings specifically when you have an implant in the OR. I mean, this is for sure really, really important. Installation sponges, it's not used in this specific study, but we use the installation sponges, the silver sponges. There's not a lot of data on that, so maybe it could improve maybe the results a little bit. By the end of the day, I'm not sure it will really definitively change our world, because it's still not a definitive coverage. So indeed, if you look at the results of the study, although it has its flaws, I think the most important is this figure 2, where you really see clear that the longer you wait, the higher the risk of recurrence, which just shows you as a message, try and keep that interval till soft tissue coverage as short as possible. The culture results don't matter. And this is something you really have to discuss within your multidisciplinary team. And when you can use local antibiotics, try and use them. The issue is a little bit from basic science as well, is that using local antibiotics and put on a VAC is not always perfect, because the concentrations of local antibiotics are lower. So personally, yes, in certain cases, we still use a VAC system for a short period of time. When possible, we also sometimes use other dressings. And still, I know a lot of colleagues that went back to a bead pouch. We don't have beads anymore in Europe, but you can make your own pancakes of PMMA, for example, if you know that you have a short period of time between the definitive coverage. But the end conclusion is cover as soon as possible.
Thoughts, Ashley?
I think the important thing is the reason for the delay and the long time frame for usage of the wound vac. And if the reason is you're awaiting flap coverage, then I think focusing on methods to work with your teams to cover the wounds earlier and getting the word out there to the plastic surgeons that really matters is important.
Yeah, I think as I apply this to my own practice, this is a question, are there any confounders? And I see one aspect is how can we shorten the time to coverage? I see the other aspect is, there's like one of our plastic surgeons or one of our partners will say vac till the end of time. And there's a certain subset of people who, maybe are not very good flap candidates. They're poor physiologic hosts. They're not going to have great vessels for free flaps. There's things about them that make them not ideal for some sort of primary intention. And so those are the people who get put on vacs forever for a reason. So certainly that probably confounds them, but I tend to believe the results of the study are true, that if we're just sitting around waiting for things to be covered or to get closed, that's not going to go well.
No, and it's not in any means the idea here to point fingers. I think it's just something to think about also with open fractures, is that I think early, well vascularized soft tissue is important indeed, also for antibiotic delivery, but also for our fracture healing, So that's a little bit, I think, the end conclusion. But indeed, there are patients where it's really difficult or even not possible. What we did before 2015, before the study, we often cultured the sponges, for example, all the different types of sponges. And it's interesting when you do that week after week. It's like a zoo that is under there, and it's becoming bigger and bigger of animals bacteria and pathogens that you never heard about. And you think, where are they coming from? But a lot of them are nosocomial. So, and that's what we saw before 2015. If you vac for a very long period of time, you get specifically, for example, the staph epidermidis, but then the MRSA, the one that lives in our hospital and on our skin, that comes back as a recurrent pathogen. This was not something that we could really find in the results here with the different centers, but if you wait long enough, yeah, I mean, you get your nosocomial flora that will get the overhand.
One other question from the chat here. When you're doing treating a fracture related infection and you've done your debridement, you've taken cultures, and then you start antibiotics, when you leave the operating room, is there a specific antibiotic protocol that you start people on? Is there anything that is evidence-based, or is it just sort of a combination decision with your colleagues on the multidisciplinary team?
Great question. So empiric therapy is, I would say, a blank page, meaning that the evidence is still not really great. So for us, that means if you have a clear FRI, specifically when there are also systemic signs, then he will get broad-spectrum antibiotics, and that's vancomycin and something against gram-negative bacilli. For us, that's also broad, and that's we call it tazocin, piperacillin, tazobactam. Certain countries even give meropenem. For example, the Swiss go to amoxicillin, and much smaller, just showing that there is not a lot of data. We would still go for broad-spectrum antibiotics when you really clearly have confirmatory signs of infection for a few days till we have definitive culture results. The gram-negative agents are stopped after 72 hours, but sometimes the vanco needs to be continued till a week or 10 days because, for example, the staph epis in our hospital in this area, there is a high rate of resistance to oxacillin. So we have to continue the vancomycin here. But the last words are not said. We don't have great data, also not from the PGI literature. So it's a nice review to write, actually. But for us, it means if you think it's infected, the patient will get empiric therapy, and we will counsel him that he will stay in the hospital for 10 days.
Ashley, anything?
In our hospital, again, it's not evidence-based, it's just a multidisciplinary discussion, but our protocol for when we don't have an organism that we know yet and we're awaiting cultures would be vancomycin, cefepime, and Flagyl until culture results return.
Yeah, we're similar. We only have a couple of minutes left. If there are any other questions, please let us know. Otherwise, I'll give either of you, my panelists, a chance to cover anything we missed.
I think Jeff was really great. You know, it's always interesting to talk infection, and you can fill a whole conference with it. So I think the cases were really, great explanation on specific issues. Also the use of local antibiotics. I think in a few years, for example, the local antibiotics would maybe even be more important than systemic antibiotics. We don't really know, but I think that's maybe one of the important messages is have a good diagnosis, an early diagnosis, be somewhat aggressive in getting your confirmatory signs or for example, your cultures, and the use of local antibiotics are important. And indeed, like Ashley very well said, I think it's a multidisciplinary team that aspect that's really important for us, and I think that's something also for the residents that's really important. We don't treat those patients alone. It's a team effort.
Yeah, I think this is a really fun topic to talk about, and it's really difficult to treat these patients. I hope that over the next 10 years, our outcomes improve and we have more data. And I really commend people like Willem for all of the research that they do in this area, because I think there's a lot to be learned. And so I think the next 10, 15 years will be really exciting to see what comes out of all of that research.
Okay, so just in a plug for other AO events, couple other fireside events coming up in May and July on the use of ring fixators and why didn't I get this reduced, and then also some standard AO trauma webinars and AO Trauma Fellows webinars upcoming as well, if those apply to you. In the 4 minutes we have left, we got one late question. Phage therapy, are you using it, and if so, when?
Yeah, I didn't touch it because I wasn't really aware if it's maybe out of the scope. But for people that are not really aware, the bacteriophages are viruses. It's a natural enemy of bacteria. They are existing all around us. They're even in our own bowel system, in the sewers. We know of their existence already 100 years. It was at that time that they did a lot of research, but at the moment that the antibiotics came, the research stopped. But now with the occurrence of multi-resistant organisms, we have a lot of research going on in phage therapy, and we're currently treating patients, specifically the ones, also the musculoskeletal infections, where there is no treatment option left. And we see good results. It's not great, but we have to remember those are end stage cases. For the moment, it's 60-70% success rates, which is actually awesome. But it doesn't really mean that we're there yet. So I think we need a lot of further study in the field of phages. Very exciting.
There's a few things that are different between PJI and FRI with regards to phages, and figuring out the mode of delivery and how to get the phages access to the biofilms, I think is the biggest challenge, which remains to be seen.
Absolutely.
All right. Well, there you guys have it. You had two incredible panelists to steer you guys through this and give you information. So thanks everyone for attending. And looks like we'll end right on time here. So thank you, everybody. And Willem, either get to sleep or get some coffee.
Thanks.